SILVA. She's going to talk on herpes zoster to VKH, Diagnostic Surprise, Unraveled.
Can I start?
Yeah, please.
Good evening, one and all. So my topic is herpes zoster to VKH, Diagnostic Surprise, Unraveled. So Vokoyanagi-Harada disease is a bilateral granulomatous panuveitis associated with exudative retinal detachment. Extraocular manifestation of the disease, like dysaceusis and cutaneous changes, occur late in the course of the disease. The exact cause is unknown, but evidence suggests an autoimmune process driven by T lymphocytes against the uveal melanocytes, treated initially with high-dose corticosteroids and then tapered over 3 to 6 month period. And the complications include cataract, glaucoma, etc. Overall prognosis for adequately managed cases is fair, with 60 to 70% retaining vision of 6/12 or better. My case was a 37-year-old male who presented to OPD with chief complaints of redness, pain in left eye, and blisters over left side of forehead for 1 week, uncorrected visual acuity 6/9 in right eye and 6/12 in left eye at presentation. Slit lamp examination revealed left eye herpes zoster stromal keratitis. The patient was treated with oral and topical antivirals, topical steroids, and cycloplegics with significant improvement over 15 days of treatment. 2 weeks later, he returned back to us with similar complaints and was found to have left eye viral keratouveitis. Oral antivirals were continued and topical steroids stepped up. Uncorrected visual acuity in the left eye dropped to 6/18. 10 days later, he comes back with pain and redness with herpes zoster scleritis setting in. On loss to follow-up, 4 months later, he comes with pain and redness, and this time in both eyes, suggestive of recurrent viral keratouveitis and a normal fundus exam. He was restarted on oral antivirals and topical steroids 6 times a day in both eyes. On 2 weeks follow-up, posterior uveitis develops, and oral prednisolone 40 mg once a day was started with close monitoring. Left eye visual acuity was 620, uncorrected visual acuity was 624 and 612 in right eye. 4 days later, both eye multiple serous retinal detachment was noted on fundus exam. FFA ICGA was advised, and the vision dropped to 5/16 right eye and 6/16 left eye. Diagnosis of probable VKH was made, and HIV, VDRL, tuberculosis, and a history of trauma was ruled out. Injection methylprednisolone 1 gram IV for 3 days resulted in complete resolution of the serous RD and improvement of symptoms. Patient is continued on oral prednisolone 60 mg and prednisolone acetate 1% eye drops in both eyes, which is gradually tapered every 10 days. The FFA shows pinpoint leaks and staining of the disc in the early venous phase. This is a fundus photo that also shows multiple pockets of serous fluid. We did a B scan to rule out posterior scleritis, which we can see a serous RD. This is at presentation with the right eye showing vision of 5/60 and left eye 6/60, where large pockets of subretinal fluid are present, and following treatment with IV methylprednisolone 1 gram for 3 days, complete resolution of the SRF with vision improving to 6/36 in both eyes is noted. So the uniqueness in my case is, what we believe is that herpes zoster keratitis could be the possible trigger for VKH in genetically predisposed individuals like this one. However, there is no literary support to the same. The probable diagnosis of VKH was made clinically, as there were no integumentary or CNS findings, confirmed by FFA findings and supported by OCT and B scan. The patient has complete resolution of the serous RD and improvement of symptoms following IV steroids. So clinical implication is that the early detection, aggressive therapy, and slow tapering of steroids and use of immunosuppressants are key to maintaining good visual acuity. Prognosis is dependent on the duration and number of recurrent episodes of inflammation. My take-home message would be timely diagnosis of variable presentations with supporting investigations may be necessary in case of probable VKH disease. In the acute phase, intravenous high-dose steroids are your best friend, followed by high-dose oral steroid tapered gradually over 6 months to reduce risk of ocular complications. Thank you.
So would you give antiviral to this patient long term, or would you not? What is your protocol for herpetic keratouveitis? Do you keep the patient antiviral oral, or you just give steroid?
So yes, lifelong in this patient. The patient is currently on.
What dose do you give?
Right now he's on acyclovir 400 mg BD.
So you didn't write that. I think all herpetics should be on long term if you're going to give.
Yes, sir, he's on.
Thank you so much.
Thank you.